canals and I put MTA, extruded beyond the apical foramen. I waited 6 months, 1 year, then 15 months. The post-op, 15 months post-op showing nice periapical healing compared to the pre-op radiograph. Look at the difference. Big lesion before the retreatment, no lesion and periapical healing 15 months after the retreatment. So I will talk about something like this. Another case, you see the broken instrument completely outside the root canal with a pre-operative lesion. So unless you do something about this, the lesion will not disappear. I remove the broken instrument here, non-surgically, then I put MTA in the root canal. 3 months, post-op showing nice periapical healing like this. So you can do this if you make an accurate diagnosis followed by the treatment planning. So it's so important. It's the most important to make a treatment plan based on the finding from the CBCT. So you see the broken instrument beyond the curvature. It's around, the broken instrument is around the second curvature, not around the first curvature. There are actually 2 broken instruments beyond the second curvature. Do you think you can remove this instrument? Of course, you can do it. I sneaked into the space on the inner wall. 1 instrument came out. If you remove the instrument on the inner wall, the second one should be easier to remove. So I took it out, and I took the second one out very easily in a few seconds after I removed the first one. The radiograph was taken to confirm the removal of the two broken instruments, and I cleaned and shaved the root canals. This was done in Kyoto, in my friend's office. So I don't have the post-op. And you see the horizontal root fractures. The tooth was moving like this. You may want to extract the tooth in this condition. However, the patient wanted me to save the tooth, even in this condition. So, okay, I got it. I will save the tooth. Don't worry about it. I know how to fix the problem. Because the root fracture occurred below the crestal bone. So if you remove bacteria, you can have hard tissue formation in those defects. So I cleaned and saved the root canals. Then again, I put MTA in those defects. And this is 3 months post-op here. This is a 3 months post-op, and this is a 6 months post-op, and this is a 2-year post-op, showing nice periapical healing. And you see the gap, the defect, was completely filled with hard tissue. Look at the difference. You see the big gap between the apical portion and the coronal portion. Now, there was no gap. You see the hard tissue formation. Even 3 months after the retreatment, you see the hard tissue here and here. You see some defect here, but 2 years after the retreatment, no more defect. You see the horizontal root fracture, crown fracture, not root fracture. So I saved the tooth the same way I did. And this is a 48 months post-op showing nice periapical healing compared to the pre-op radiograph. So how do you increase your success rate in non-surgical retreatment? As I told you, it's most important to make an accurate diagnosis followed by treatment planning. Without making the treatment plan, you have no idea if you can be successful or fail. So that's why you have to make an accurate diagnosis and the treatment plan. However, I'm sorry, I don't have time to show you how to make an accurate diagnosis and the treatment planning. I'm sorry, but next time if you invite me to Vietnam, I will promise I will show you how to make an accurate diagnosis and treatment planning. However, I want to show you just the definition of success, because if you don't set your goal with your patient, then you know what's going to happen. Because your patient will pay you for what you do. So you have to provide enough information for the patient. Then the patient should set a goal of success. Then if you want to increase your success, you have to be a really specialist. Don't call yourself specialist unless you have these. What is a specialist? The specialist is a person who has comprehensive and authoritative knowledge of or skill in a particular area like endodontics. So specialists can make an accurate diagnosis, and specialists can prioritize the treatment plan. The specialist can solve the problem very quickly. You don't want to wait 1 year, 2 years, 3 years, 5 years. You should solve the problem in a shorter time, very quickly. Look at the pandemic. The COVID-19 is gone? I don't think so. They are still there, out there. So, like the guy in the United States, I forgot his name, Thomas, what's his name? The guy who talked about the pandemic. I forgot his name. You know his name? Fauci, yeah, Fauci. The American doctor, the Fauci. Yeah. Yes, he was. Obviously, he's not a specialist because he didn't solve the problem quickly because it's still out there. So he can call himself a specialist, but he's not a specialist at all. So you have to, in order to be successful, and if you want to call yourself a specialist, you have to make an accurate diagnosis, prioritize the treatment plan, and you should solve the problem quickly with effective treatment. And what is the accurate diagnosis? Accurate diagnosis, in order to have the accurate diagnosis, you have to have the understanding of pathological process, and you have to have the recognition of disease by means of signs, symptoms, and tests, including clinical and radiographic examinations. For example, as I told you, you have to have the definition of success. What is a success? Everybody has everybody has a different success standard. But if you look into the dictionary for success, the dictionary shows success as the attainment of specific goal. So if you want to call it success, call your treatment success, you will expect the lesion to disappear in a shorter time. Then you can call it success. Or for the patient want you to remove the pain. If the tooth becomes asymptomatic, you can call it success. So there are 3 standards. You have to make the lesion disappear, or you make the symptomatic tooth disappear. In other words, you will make the tooth asymptomatic. Or some patient just wants you to retain the tooth, and you can call it success if you can retain the tooth in the mouth. So there are three standards. In general, we can, as a dentist, we can call it success only when the lesion is gone. But most of the patients don't care about the lesion. They only care about the pain. So for example, here, you see the periapical lesion on the root. You see the big lesion. You see the lesion here, elevating the sinus floor. Big one. I retreated this, and I waited 6 months. I took a radiograph and CBCT that shows the lesion size completely reduced. However, you still see the lesion, apical lesion here, even here on the radiograph. But the tooth was completely asymptomatic. The patient was already happy. Thank you, doctor. Thank you for fixing my problem. I'm happy. But I was not happy because I saw this. For the patient, you can call this success. But for me, I don't want to call this success because I see the lesions. So that's why you have to set your goal with your patient. If you wait another 6 months, the lesion will be gone. But here, if the patient goes to another dentist, if something happens, and that dentist will find the lesion on the root. And the lesion, as long as you see the lesion, you want to start the retreatment if the patient was not provided enough information. So you have to discuss this before you start your treatment. Very important. So if your patient comes to your office and you took radiograph, would you retreat the tooth? If you didn't hear my story, would you retreat the tooth in this condition? Probably you would want to do this. Okay? So it's very important. It's important to inform the patient of what's going on. And it's important to set the goal with the patient before you start the treatment. This is how you control the situations. Otherwise, you may be sued even if you did a good job because of this. So you have to tell your patient, wait 6 months until I see the lesion completely gone. Another example, you see a huge lesion. Would you extract the tooth? Anybody here? Would you extract the tooth in this condition? Nobody? Why? Because you saw this, right? But some dentists, they want to extract the tooth in this condition, but I wouldn't. So I treated this tooth. I waited 6 months. Look at the size of the lesion, completely reduced in size compared to the lesion on the pre-op radiograph here and here. If this patient goes to another dentist, I feel something from the upper molar, and the dentist will take a radiograph, maybe a CBCT, and the dentist will discover the big lesion. Do you consider this lesion big or small? Of course, you will consider this lesion big. Then the dentist may say, okay, I have to do the surgery. And anybody retreating this tooth was not good because the lesion is not gone. Maybe that dentist will say that. However, if you wait 1 year, more than 1 year, you will see this, right? But if the dentist, that another dentist who saw this without waiting 1 year will probably do the surgery. And surgery may not work or could work. You don't know that. If you are good, you could fix the problem. But if you just wait 1 year, 6 months, or something like that, you will see the lesion is gone. So that's why it's very important to set a goal with a time limit. Without time limit, nothing can be successful. So this is a systematic review showing progression of healing. So if you wait in general 3 months, 40% of the cases will heal. If you wait 1 year, 60 to 70% of the cases will heal. If you wait 2 to 4 years, 80 to 90% of the cases will heal. If you wait 6 years, more than 95% of the cases will heal. So it depends on the time. Even if you wait 6 years, maybe 5% or 4% of the cases is not healing. Okay? Very important to discuss this with the patient before you start your endo treatment. So the AAE and Foundation approved the definition of the success. If you consider the tooth healed, the tooth must be functional, asymptomatic, with no or minimal radiographic periapical pathosis. So the goal is not to remove. The goal is to remove infection, simply remove infection to induce periapical healing. And you have to use the CBCT to detect the lesion, because 2D radiograph is not accurate. How many of you have CBCT in this room? Please raise your hand. CBCT? I see only one person raising the hand. Okay, maybe a few. It's very important to have the CBCT. Do you limit your practice to endodontics, just endodontics, or you do everything? Everything or just endodontics? Everything. Okay, good. But you have to have CBCT to be more successful in endo treatment, because if you have an accurate diagnosis using the CBCT, your success rate will be improved. So this is the success rate with an asymptomatic tooth or without periapical lesion. So the tooth without symptom, look at them. The success rate with a tooth without a symptom is higher than the tooth without periapical lesions, like this. So it's easier to make the tooth asymptomatic than remove the periapical lesions. So usually 9 to 13% higher for the tooth without symptoms than the tooth without periapical lesions. So this information was provided by Professor Simon Friedman, Canada, University of Toronto, and he looked at 69 studies on the outcome in the treatment. There are 69 studies on outcome studies from 1990 to 2023. I'm sorry, 1956 to 2023. But any studies before 1990 were outdated because they didn't use a microscope. How many of you have microscopes in your office? Microscope. 3? Oh my God. Okay. You have to have CBC, I'm saying, you have to have microscopes in order to be more successful along with the CBCT. If you don't use the CBCT or microscopes, the success rate will significantly drop. So we should look at the studies between 1990 and 2023. But there are many studies on the outcome. And the gap between the lower success rate and higher success rate is almost 70%. So it's very confusing. So because they have made standards. If you look at those studies, there are many standards. They have their own standards. So it's not, it's not easy to just look at one study. So we just want to look at the studies with the same standard. And there will be 6 studies with a good standard, the same standard. We call them current best evidence. So there are only 6 studies with the same standard. And if you look at the success rate on retreatment, non-surgical retreatment, the success rate is from 74% to 90%. So the gap between the lower success rate and the higher success rate is only 20% or just a little bit more. So if you want to be more successful, like a higher success rate, 90%, you have to do something differently. So that's what I want to talk about. So if you always do what you've always done, you will always get what you always got. So if you want to improve your success rate, you have to approach the tooth in a different way. Don't do the same. You need to change. Okay? Unless you change the way you treat the patient, your success rate will end up being the same. You know Mark Twain, right? He's the writer of the famous adventure of Tom Sawyer. He likes something advantageous. He likes adventures. So he goes out and do something different every day. Of course, he was already dead, 1910, but he left many good stories about adventure. So, how do you improve your success rate? Of course, you need to have an accurate diagnosis followed by the treatment planning, but I don't have, as I told you, I don't have time to show you everything. So I will jump into the causes of post-treatment disease. There are 2 main factors for the post-treatment disease. One is microbial, the second one is non-microbial, including foreign body reaction or cyst. So if you look at the non-microbial factor, you will see true cyst or cholesterol crystals. But there are not many. So what are cholesterol crystals? They are brought by macrophage. Macrophage will take cholesterol in the blood vessels and take it to the cyst. Take it to the apical regions and release it. That's why you will see lots of cholesterols like this. They are cholesterols. And if you have lots of cholesterols in the apical region, they will affect or delay healing negatively. And they are associated with the cyst because macrophage will bring cholesterol to the periapical region, creating a foreign body reaction and delay the healing. So you will see them in the majority of the cysts. So if you look at the periapical region, they are not always a cyst. The majority of the periapical region is granulation tissues. What about the cyst? 21%. What about the abscess? 4.3%, very few. And what about the scar tissues? 2.2%, very rare. And this is another study. They did periapical surgery. They did root end dissections, and they examined the root end, dissected the root end. And they found the lesion consisting of granulation tissues was 94%, almost 95%. 5% cyst, 95% granulation tissues. So whenever you see the lesion, they are usually granulation tissues. 5% cyst, then you have to do the surgery in order to make the tooth heal. So 95% are granulation tissues. So that's why if you remove infection from the root canal, you will have healing. 5% you have to do the surgery. So I want to just talk about non-surgical retreatment. If you do it in the right way, your success rate will be 95%, because the majority of the infection are intracameral. But it's not just infection removal, because 41% of endodontically treated teeth were extracted due to restoration failure. So if you have poor coronal restoration, your endo success rate will be reduced. So it's important to have the coronal restorations. For example, this is very, very famous study done by Ray and Trop, 1995. Old study, but still famous. So if you look at them, here, if you did a good endo, but with poor restoration, poor crown, with a big marginal gap, your endo success rate is only below 50%. Okay? You did a good endo, meaning you have root fillings to the working length. But if you have a poor coronal restoration, your endodontic success rate will be reduced, significantly reduced. However, you did not do a good job in endo treatment, but you have perfect or good coronal restoration. Your endo success rate is higher, almost 70%. It's very strange, right? So endo success rate, endodontic success rate will depend on the coronal restoration mostly. So you need to focus on the coronal restoration than the apical fillings. This is what they found. So coronal seal has more decisive impact on the treatment outcome than the apical seal. Because you know where the bacteria come from. They come from the oral environment. They do not come from the apical end. They come from the coronal, the coronal area. They come into the tooth from the space between the coronal restoration and the root. However, if you look at the systematic review and the meta-analysis, both are important. You have to have the coronal restoration, good coronal restoration, and you have to have the apical seal, good apical seal. Both are important. So, as long as both are important, you have to focus on both the apical seal and the coronal seal. But many of you said you do both, right? You do endo and you do the coronal restoration. So that's good, because your success rate depends on the coronal restoration as well. And first of all, you need to remove the crown, because look at the radiograph here. you see the gap. And you see the gap between the coronal restoration and the root. So I stained the dentin with Carrier's detector dye. You see the red. They are all soft dentin. I removed the soft dentin, then I did the root canal treatment, and this is the post-op. I always finish the endo treatment in one visit. But when I didn't have time, I had no choice but to do it in 2 visits. Domenico Ricucci from Italy showed this. He examined 39 obturated root canals that were exposed to the oral environment for more than 3 years without a coronal restoration. But he found bacteria only in the coronal dentin. Here. If you look at the apical 1/3, there are no bacteria in the dentinal tubules. If you look at the middle 1/3, there are no bacteria in the dentinal tubules. But you do see bacteria in the coronal 1/3. Here, you see the bacteria. You see the purple stain. They are bacteria. So even there was no coronal restoration, the root was completely exposed to the oral environment. There are no bacteria in the apical 1/3 or in the middle 1/3 of the dentinal tubules. So you need to focus on the removal of the bacteria from the coronal dentin, because they are there. Why you have more bacteria in the coronal dentin? Because in the coronal dentin, you have significantly more dentinal tubules than the apical dentin. So this is the reason why you need to spend time removing bacteria from the coronal dentin. So this tooth was extracted because of the vertical root fracture. And this is the tooth from here. You see the vertical root fracture. But look at the tooth discoloration. There was no tooth discoloration in the apical 1/3. But look at the middle 1/3 and the coronal 1/3. You see the tooth discoloration because there are significantly more dentinal tubules in the coronal 1/3 compared to the apical 1/3. So bacteria usually you find in the coronal 1/3 because of the more dentinal tubules. So this is another case with a big lesion on the first and the second molar, upper molar. I was not able to reach the apical 1/3 or even the working length. However, this is 4 months post-op showing nice periapical healing compared to this. Look at this here. You see, I was not able to reach the apical 1/3. My feeling stopped only in the middle 1/3. There was no shaping, cleaning in the apical 1/3. However, you see the complete periapical healing on the second molar, right here, as well as the first molar. So if you have good coronal restoration, you don't have to always to reach the working length, the apex. So just if you cannot go to the working length, it's still okay. But make sure you have good coronal restoration. So the treatment outcomes depends more on the marginal adaptation of restoration than that of the root fillings. Because usually many dentists, almost all the dentists, use the Garapacha and the sealer that do not bond to dentin. So it all depends on the coronal restoration. If you use a material that does not bond to dentin, you will have the coronal leakage into the periapical tissue. So if you have the perfect coronal restoration, then you have good seal because there are no bacteria coming into the root canal. The crown protects the tooth from bacteria coming into the tooth. Actually, this is another study done by Domenico Ricucci and Sekira, here, 2010. And this is Garapacha, and this is the root canal wall. They found the coronal leakage, bacterial leakage, into the periapical tissue in all the cases. As long as you use the Garapacha and the sealer, you will have the leakage. That's why they concluded it's important to have the coronal restoration, good coronal restoration. And this is my case. I did this in 1996. I was much younger, of course, and I was so busy. I saw 55 patients a day. I did everything. I was a general dentist. Now I'm an endodontist. Then, because I was so busy, I forgot to fill the root canal. And I placed a metal post here. I took a radiograph. Then I was surprised to see the radiograph. There was no root fillings. Oh my God, I forgot to fill the root canal. I thought I did it, but I didn't. I waited because I did a good job. I already used the microscope. I isolated the tooth with a rubber dam. So I did everything, except I didn't use I didn't put the root fillings. Of course, at that time I used Garapacha and the sealer. But I waited 2 years, and this is a 16-year post-op, showing nice periapical healing. Look at this. No fillings, but good periapical healing. Lucky. It's not just lucky, because even if you have the Garapacha fillings in the root canal, I would have the same result, the same outcome. Because Garapacha does not, as I told you, bond to dentin. So that's why it doesn't matter. What matters is a good coronal restoration, not poor coronal restoration. So I had good coronal restoration. That's why I had a healing. Right? So focus on the coronal restoration, mostly. But you have to clean and shape the root canal, completely isolated from the oral environment. However, this is a 24-year post-op showing periapical lesion again. Yeah, sorry, this one. And this is a CBCT, the sagittal view showing the apical lesion. Because dentin was exposed to the oral environment, and I didn't have the root fillings. Even I had the Garapacha fillings in the root canal, the same thing would happen. Because Garapacha, as I told you, does not bond to dentin. Because you have significantly more dentinotubules. When exposed to the oral environment, the bacteria will be happy to come into the root canal and generate many more, and happy to go into the periapical tissues, creating the inflammation. What about the sealer? If you don't use bioceramic sealer, which expands, you will have shrinkage between the root fillings and the root canal walls. For example, if you look at zinc oxide-based sera, they will significantly shrink. If you look at the resin-based seras, they also shrink. But bioceramic sera is the only material that will expand. So use the sera that will expand. Okay? How many of you here use bioceramic seras? Please raise your hand. Okay. Some people, maybe 20. Okay. So don't use, it's okay to use the Garapacha and the sera, but don't use zinc oxide-based sera or resin-based sera. Just use bioceramics or MTA sera, which will expand. Like this. This is zinc oxide Usinol sera. You see the shrinkage here and here and here. But if you use MTA, you will see it expanding. So what can be responsible for non-healing cases? So look at this. You see perfect coronal restoration, composite, no gap. But you see the big lesion here. Why you see the big lesion on the root? Because of this. You see the space with necrotic pulp tissues. Because of the necrotic pulp tissue that you didn't remove during the endo treatment, this will create the periapical disease. Because you see lots of bacteria in the defect. You see the Garapacha and you see the necrotic pulp tissues just next to the Garapacha. And if you did the root end surgery, you see the gap, spaces. This is responsible for the periapical disease. So if you don't use the microscope, you will not see this. If you don't use the CBCT, you will not discover this. So if you use both the microscope and the CBCT, before you touch a tooth, you will discover this, especially with CBCT. So your target in retreatment will be like this. Always find the defect that you cannot touch with your instrument. So any bacteria, are there any bacteria in the apical 1/3? Because we know that we don't have bacteria in the apical dentin. But any bacteria in the root canal space? Yes, we do. Intracanal biofilms are present in the majority of cases with large periapical lesions. So the reason, even if you have the good coronal restoration, to have the periapical disease is the biofilms inside the root canal. There are many studies supporting this. So the only reason you still see the periapical lesions is the biofilms, intracanal biofilms. So biofilm will grow on the necrotic pulp tissues. This is the pulp, and this is the biofilms. Like this. If you see the gap, the plant will grow in the gap. If you see the gap in the root canal, the bacteria come in there and proliferate on the necrotic pulp tissues. So don't leave the space empty. You need to get rid of the necrotic pulp tissues. So there are many studies showing similar result. 90% of endodontic refractory cases have biofilms surviving retreatment, non-surgical retreatment, in the hard-to-reach areas, including aneurysms or apical ramifications, like this. So your target in retreatment, if you see the periapical lesions on the radiograph, will be those small anatomical spaces, like here. How do you find those small anatomical spaces? The CBCT or the microscope. That's why I keep telling you the same story. You have to have the CBCT and the microscope in order to improve your success rate. So that's why it's important to use the CBCT and make an accurate diagnosis. Actually, the space, the apical space of the root canal is 3 times wider than the coronal root canal spaces. And the area that is not touched by standard conventional nickel titanium instruments is almost 70% of the entire root canal due to the space being oval rather than round. Because if you look at the apical root canal, they are most likely not round, oval. If it's oval, you cannot remove everything from the oval root canal. So this is the reason why your endo retreatment will fail. So as I told you, if you do what you have always done, you will get what you always got. So unless you change the way you retreat the tooth, you will have the same results. Do something about this. You can place your rotary instrument here, but what about this? Where you have bacteria outside the rotary instrumentation. So biofilm formation is associated with persistent periapical lesions. So in the treatment, and if you see the periapical lesion, they are most likely biofilms. You have the biofilms inside the root canal. And Candida albicans, Enterococcus saccharis, and actinomyces were the most prevalent microbes associated with persistent apical periodontitis that do not respond to conventional non-surgical retreatment because of the untouched biofilms remaining in the defect. What about the Garapacha? Is Garapacha okay or not okay? They found biofilms on the Garapacha fillings as well as the sealers. Here, you see this is the Garapacha, and they found lots of biofilms on the Garapacha fillings. So Garapacha is not okay at all in the treatment. Bacteria love proliferating on necrotic pulp tissues and also Garapacha fillings. If you use Garapacha cones in the treatment, do you know what will happen? You will have more bacteria proliferating on the Garapacha fillings. If you extrude the Garapacha cone beyond the apical foramen, you will have more bacteria and biofilms on the extruded portion of the Garapacha filling. Look at them, they're all bacteria, biofilms. So biofilms can form on Garapacha and necrotic pulp tissues. Don't use Garapacha in the treatment. So if Facalis adhered well to the Garapacha cones, even with zinc oxide eugenol, which will shrink, or calcium hydroxide sealers, tissue fluids such as saliva and serum play an important role in biofilm formation in Garapacha. So Garapacha can be easily contaminated, especially together with bacteria. If there are bacteria on the root canal wall, and if you use Garapacha cone, you will increase the number of bacteria because of the material you use. So biofilms are more likely to be present in association long-standing pathologic process, including large lesion and cyst. So whenever you see the lesion, long-standing lesion, you can ask your patient, how many years ago did you receive the endo treatment? And when she or he said, okay, 10 years ago, or 20 years ago, or 5 years ago, the longer, the more biofilms. Okay? If she or he said, your patient said, I received the endo treatment only 5 months ago, that's okay. Maybe there is almost no biofilms. Once you have the biofilm, it's very difficult to get rid of. So extraradicular biofilm was present on the external root surface of treated teeth with persistent periapical lesion. So usually, when you see the biofilms on the root surface, actinomyces is responsible for the extraradicular infection. They play an important role in extraradicular biofilm formation. So whenever you see the biofilm on the root surface, actinomyces are responsible for that. They create extracellular polymeric substance, protecting the bacteria community inside. Look at the yellow substance. They are extracellular polymeric substance. We call this EPS. So you see EPS here and here and here. So EPS provides physical stability and resistance to mechanical removal and antimicrobial and host immunity. So your immune system will not reach the bacteria because of the protection of EPS. However, if you take close look at the biofilms, you see some defects, some spaces in the biofilm community. So if you can get sodium hypochlorite into those small defects, you can disrupt the biofilms. So that's why it's important to use higher concentration of sodium hypochlorite. If it's too low, you cannot reach those spaces. This is EPS, and they are water channels. Because they need water, just like a human, to grow and to stay stable. So in order for the bacteria to get water, they need some empty spaces. And water is provided for them. In addition to EPS, biofilm can be calcified because bacteria produce acid, then dentin will be dissolved, and they take hydroxyapatite. That's why they can be calcified. Once the biofilms are calcified, it's more difficult to remove. So what kind of biofilms are produced by? So the majority of biofilm forming microbes on the root canal dentin are Enterococcus faecalis and Candida albicans. So we know the target. If you remove Enterococcus faecalis and the Candida albicans, there will be no biofilms. So our targets in the treatment is to remove infection, including mainly actinomyces and Enterococcus faecalis and Candida albicans. So there will be no biofilms. So if you classify the bacteria inside the root canal into several species, they found significantly more they found Enterococcus Enterococcus faecalis significantly more, and also it is associated with asymptomatic cases of primary infections. So if you have Enterococcus faecalis, they hide themselves very well because the tooth is usually asymptomatic with Enterococcus faecalis. But if you have gram-negative bacteria having LPS, lipopolysaccharide, they will create acute infection, acute periapical periodontitis because of LPS. Macrophages respond very quickly to LPS. All the gram-negative bacteria have LPS, but they don't have LPS, Enterococcus faecalis or actinomyces. They are all gram-negative. They are all gram-positive. Gram-positive bacteria do not carry LPS. That's why they are very quiet. They will not cause the body to respond very quickly. That's why they can hide well. They can proliferate without creating an acute inflammation. So what is Enterococcus faecalis? Detection rate of E. faecalis was higher in persistent infections compared with untreated chronic periapical periodontitis as primary infections. So this is the cause of the persistent apical periodontitis because they produce biofilms. And you see also biofilms on the root surface. We call this extraradicular biofilms. So you will find biofilm on cemento surface, and you will find biofilm also in periapical soft tissues. So biofilm outside the root canal can be either on the cemento surface or the lesion itself, periapical lesions. How do you find why the biofilm can be formed on the root surface? Because in long-standing inflammation, the host defense become less effective, and microbial invasion of the PA lesion may occur. When the immune system goes down, meaning our defense system goes down, the biofilm can be formed because you will have lots of invasion from the bacteria. And these bacteria will survive in granulation tissues. They are mostly actinomyces. Actinomyces can survive the periapical tissues. So unless you remove actinomyces, you will not see the healing. That's why you have to do the surgery in this kind of case.